Good morning, and nice to be here this morning to discuss the topic of PET-CFR in diabetes. As we just started with the MIBI studies with SPECT, Dr. Prabhu presented, and we just listened to the MRI2 and our predecessors in the morning describing what change occurs. So we are on the PET, the positron emission tomography. So very quickly, there are few differences mechanically and instrument wise. What's the difference between two techniques? Because I understand there are a lot of physicians in the room this morning who look at diabetes and heart disease. So like as Dr. Bandukwala said right in the beginning, you really want to decipher which test to use when. So when we put a lot of things, at times there is a confusion, guidelines and all. So it's good for physician to know at least the basic minimum, when he's calling for the study, what is going to give. So the SPECT and PET, the PET uses different isotopes, high sensitivity and spatial resolution, and that makes the imaging much more better with PET. But of course, you need PET, you need different set of isotopes, may not be there at one center and other. So is the deciding the choice. So how do the physician choose? I should go for SPECT or PET. So we are talking of the flow reserve, cardiac flow reserve this morning in diabetes. So that's very specific scenario. So technologically, the PET is a much advanced tool giving much better sensitivity counts. So it makes the imaging better and quantification. We are quantifying the blood flow, where in SPECT we are giving in form of the relative blood flow as compared to the next segment, which could be normal or abnormal. But here we are quantifying. So these are 2-3 very important things as I enumerated about the PET. That's what we should know. So the traces that follow the myocardial blood flow in a more linear fashion than the current SPECT tracer. That is important. The tracer of PET have more linear relation with the change in the blood flow, the hyperemia and all. So you are quantifying, you need to have the better technique. So technologically, the PET isotopes are better for this purpose of measuring the blood flow or blood flow reserve, which we need in the context of diabetes. So risk stratification, as Dr. Prabhu is the SPECT, a lot of data has been done, but herein we are adding on the CFR, the coronary flow reserve, and that comes by the PET. So we are adding something here with the PET technology. So the ischemia, there are two major resistance. So the diabetes is a small vessel disease. So epicardial arteries, arterioles, capillaries, one has to understand. So the microvascular resistance is coming from the capillary network. So that's what goes, astray in diabetes, the small vessel disease, and there may or may not be the epicardial artery involved. So how to factor that in the prognosis or treatment follow-up of the patient? So we need to have the CFR if you want to add that their thing. So the blood flow increases automatically on demand, exercise, pharmacological or neuro. So in diabetes, that is offset. The other major determinant or the physical form, anatomical form of disease may not yet exhibit, but these things started changing. And CFR is the method to catch those things early and factor in the treatment. So if you are trying to do that, then you have to do the CFR. As Dr. Jadhav mentioned earlier about the calcium, and he's saying that calcium is one important, that is there too. But calcium is also part of the evolving paradigm of the changes in the capillary walls which are happening, and calcium is one of those. So this is an important slide. I would like to take a look at it. So if we are looking at the flow, the epicardial artery, and that is the FFR, fractional flow rate comes from here. So if I'm taking the resistance vessels into consideration where adenosine works, then it gives the holistic information of CFR, or we can call the myocardial fraction reserve or the coronary. So these are the resistance microcirculatory resistance comes into play. So by doing CFR and MFR, we are measuring these, the earlier form of the diabetic or any other metabolic changes which are affecting the measurement of the flow. So the resistance in small vessel disease, the R2, that is the resistance of the micro vessels, is getting, which normally you should get auto-regulated, doesn't get auto-regulated. So there is a flow impairment within the microvasculature. So this is the historical physics explanation that the baseline flow remains stable up to more than 70, as we say here, 83% of the stenosis. And the hyperemic flow starts diminishing even at the 40% stenosis. So if we are talking and diabetic control, all kind of diabetic drug, when the microalbuminuria comes in the urine, all those factors, they are based on the permeability of the microvessels and how they are behaving. And these changes are there much before the stenosis comes. So the whole paradigm, are we talking about the anatomical stenosis percentage wise, or we are incorporating these changes of the coronary flow reserve? So these start coming up much earlier. So this technique catches those changes. So diabetes, subclinical thing, everybody mentioned coronary vascular dysfunction, diabetic myopathy, and ultimately the heart failure happens. Molecular level, calcium is coming, the structural remodeling, that is the calcium deposit, everything is going on together. So what is the sum total? How do we measure? Either we measure each of these events individually and correlate them with prognosis. People are doing that, which is a very difficult task. And they say, okay, let's combine these 2 or 3 techniques, molecular techniques or imaging things. So the change is at the microvascular, what I'm trying to show there. And CFR is a very good tool to measure those changes before anatomical and other changes come into play. So the principle is the myocardial activity and the arterial blood flow. How do we calculate these? So PET is capable of measuring the myocardial activity and activity in the blood flow, and that gives you the CFR in very simple terms. And the 2 major tools are rubidium and ammonia at present. And ammonia is only available where cyclotrons are there, all those centers. And rubidium is through generator, still expensive in India, so nobody is importing it as yet, unless the physician orders more investigations to determine the CFR. Then these things will come into play. Otherwise, these will remain theoretical in India. Ammonia we are doing, lot of us centers who have the cyclotron, like here at SGPGI, we are doing ammonia, AIMS, PGI, Chandigarh, but it does need a cyclotron. Other centers cannot do it unless they go to rubidium, and cost issues come into play. But the tool is very good. You want CFR, you have to resort to one of the things. So normally when we are doing SPECT or even PET, we are looking at the late images, the stress rest images, and show the difference where infarct is or where this is. Whereas in the perfusion CFR studies, we have to look at the earlier 2 to 4 minutes. So it's a dynamic early study in which the first flush of blood goes, ammonia goes, rubidium goes, mixed into the blood. So that requires special technology and special effort, which is very much available. Software is there on all the good PET cameras, and it can be easily used. So just to make out, the standard SPECT is late imaging, and the CFR is the early part of the imaging. So some agents, oxygen 15 is the best agent, then the ammonia. In between there is a fluorpyridaz, which is in phase 3 trial, F18. Now once that comes into the play, each and every PET center which now does oncology can also do the CFR. So that is very, very much there in third. So you see the system, maybe the correlation of increase in the blood flow per gram of the tissue infused is best with the oxygen 15. That's not easy to do even at the cyclotron. So the next best is the ammonia, which most of us with cyclotron do it. It has to be ordered. Rubidium is still lower, but very popular in America and all, because it comes in a bucket, the cow, so you can milk it every day whenever the patient comes. So this is the hierarchy of the agents which are there for the best use. All of them have been correlated with the prognosis and information they got. So despite this difference between their linearity with the blood flow, they have done good job clinically, and there is a lot of data on that. So here is a table of oxygen 15, ammonia, rubidium. Fluorpyridaz is the new kid on the block, fresh ongoing phase 3 trial, and this will make everybody with F18 or PET do this extraction study. We are doing the ammonia study. So there is a protocol quickly. So there is rest stress after adenosine has to be done, and in between you have the transmission CT or the scout CT. So this is the kind of bullseye image, the parametric representation of what wall is perfused, that shows how it came in the early phase and where it was retained, which is the uptake, retention, and then we calculate from these through the formula the myocardial perfused, which segment was perfused at what level, and then on the right you see the scale, the color scale, which tell you how much each segment is, how much ml per minute per gram of the tissue, and 2.3 above 1.8 is considered normal with ammonia. So you get from the software the very nice view. So this is a normal study done here at GPGI with ammonia. So this is giving stress, mean, LAD, LCH on the bottom table. All the image visually are also showing. At time in microvascular disease, you may see some areas of, confused low uptake, or this which you may like to call it as ischemia, as in the standard spectrum of this study. But if you look at the quantitative parameters of extraction, the reserve or the CFR, so that is all falling within the normal limit. So you know that this is nothing but a normal ammonia study. So this is another study showing the same thing in various segments. And there are a lot of clinical studies which have been done to relate this CFR with the hazard of getting the disease over the years. And in Europe, these are, reimbursable. The CFR studies are reimbursable. So they have included it in their cascade of this thing. So the other thing is the sympathetic involvement in the diabetes. So with adenosine hyperemia and diabetes, this cold pressure test with CFR changes, you can find out the real change. So you see that is happening maximum in diabetes, and it is very easily discernible, no coronary, no major disease in the vessel, but you do these tests. So there is a major change in the CFR or the blood flow, which can be discernible by this technique. So I will skip few slides, and of course the correlation of all the events with the cardiac death and all causes of death with the percentage of myocardial involved, that is also very well correlated with the CFR. So at the end, so where should we do, as the question was? So in a balanced or triple vessel coronary artery disease, functional characterization of angiographic coronary stenosis for guiding percutaneous intervention, risk stratification, and most importantly, the microvascular dysfunction and microvascular angina, microvascular cardiomyopathy. You want to know in cardiomyopathy, is the microvasculature really involved? Because you will be controlling with by drug. And of course, in such patient with microvascular disease, the disease once you have given insulin and other diabetic modifying drug, you see a significant change in the CFR. So in the post treatment response scenario, you use it. So predominantly microvascular disease and the post treatment response scenario and early detection of the vascular disease, you use it. Thank you very much.